Welcome to the LACNETS webinar on Net Vitals. I want to welcome everyone joining us online today for this webinar. We're very excited to be here today with our panel, and especially for those of you joining us all over the world. We are live in sunny Aliso Viejo here in California at TVP Studios, and I want to thank Rich Tamayo and for his expertise in our videotaping today and live streaming, and also Lindsay Judavine, our Director of Communications for LACNETS. I am Giovanna Imbesi, and I'm the Executive Director of LACNETS. We are doing this today for Net Vitals. So what is Net Vitals and why is it important? This is a tool that was developed out of a conversation that started at the Healing Net Summit back in February of this year. And it was about patient communication with physicians and physician communication with patients. And how can we do better? And out of that conversation came Net Vitals. And Net Vitals is about a 20-question questionnaire, which works both for the physician and for the patient to help the patient understand what types of things they need to know about their disease, what things can be helpful in them understanding and tracking their disease, and for the physician to be able to have kind of a snapshot of what their disease state is. And so Lisa Yen, who you'll meet in a moment, is our LACNETS program director. Lisa and I developed this with Dan Lee, Dr. Dan Lee from City of Hope, as our medical advisor. And along the way, we had lots of help. This has been a living document. We're many revisions in. Look forward to your feedback as well today. And I want to thank a few people. Josh Mailman, who will be with us, who's the president of NorCal Carcinet, was instrumental in helping us refine this and also present it to the NorCal Carcinet group meeting. I'd also like to thank Brent Curry, who was instrumental in the very beginning from LACNETS to help us get it into a format that we could share. So we are very excited to be here. Thank you so much for joining us. And I will now pass it to Lisa Yen to say a little bit about why Net Vitals is important and introduce herself. Lisa?
Hi, I'm Lisa Yen. I'm the LACNETS program director, and my husband is also a patient, so I'm a caregiver. My background is as a nurse practitioner, although not in neuroendocrine tumor, and I'm currently a health coach. And I was also at the Healing Net Summit with Giovanna, Josh, and Dr. Lee. And when the workshop on the physician-patient communication presented to the whole group with Josh moderating, this issue really spoke to both Giovanna and myself. And we really felt that it was important for us as patients, from the patient side, to educate ourselves that knowledge is truly power, and that there is so much information that we're being given, and there's a potential to feel very overwhelmed. So what could we on the patient side do for ourselves at home to prepare for the appointments, to empower ourselves with the knowledge, and to put it as more of a teamwork effort instead of waiting for the physicians to give us the information during or after the appointments, to arm ourselves, to prepare ourselves, to come in ready with all the documents that are needed to understand as much as we can of the information before the appointment, and to help the doctor so that they could better formulate a plan for us.
Thank you, Lisa. And I'd just like to say the Net Vitals form, in case you haven't already done so, is available on the LACNETS website. It's www.lacnets.org, and you will see Net Vitals. It's a downloadable form. It's about 6 pages long. And so if you're at home following along, that's the document that we are working on. So now I'll pass it to Dr. Dan Lee at City of Hope.
Thank you so much, Giovanna, and thanks everyone for joining us today for this webinar. So I'm very excited to help introduce NetVitals to you. As what has been spoken by Lisa as well as Giovanna, NetVitals was really a collaborative effort that came out of the Healing Net Foundation meeting between physicians as well as patients. And I think our goal is, from a patient perspective, is that oftentimes you have limited amount of time to spend with your physicians. And as a result of that, any way possible, we can make the encounter more efficient so that we can really individualize the care of patients with neuroendocrine tumors. That's going to be very helpful. As co-director of the neuroendocrine tumor program here at City of Hope, oftentimes, even when I'm not able to provide a new therapeutic option for patients that I see in consultation, by just explaining the disease a little bit better to them, which I hope NetVitals can help to do so, patients feel that they get a great experience from that and they are empowered as a result of that. From the physician end, I think NetVitals really serves as a basic starting point on which, for experts in the field, you can understand the disease state of the individualized patient so that you have a more efficient patient encounter and really tailor the overall discussion during the patient-physician encounter to that patient specifically. If any of the other physicians in the community that might not know neuroendocrine tumors as well, it also starts as a initial foundation point because it helps them realize if there's some type of information that might be missing that they might not be aware of, then it's a starting point for them to maybe get better understanding about that disease or maybe reach out to an expert physician so that they can ultimately provide a really high level of comprehensive care for that neuroendocrine patient. So I hope that as we go through this process, we will able to better define this, and any suggestions from the group would be really appreciated.
Excellent. Thank you so much, Dr. Lee. It's really helpful to hear the physician perspective as well as how this can empower patients. So next up, I'd like to introduce Josh Mailman, president of the NorCal Carcinet Group.
It's great to be here as well. I think I'm spending the entire month of September working on communications and how doctors and patients can communicate better together and how to go through that. And I think the working on NetVitals is just one of the aspects of tools that we can have to actually forge this better conversation. I don't think it's the only tool that we have. We've developed some of these like survivorship roadmaps that people get sometimes post-treatment. And since we live in a chronic condition for a lot of us who will have this over many, many years, we never really got to this survivorship roadmap and something that documented our disease so that when we see other physicians, they can easily ascertain what's going on with us and where we've been. So this is, I think we started this not as the NetVitals, but as a passport, as a way to say, this is where I've been, this is my journey, so you know what my journey is, so I don't have to repeat that part and you can evaluate it. I may have immediate concerns right now, but here's the map of where I've been. And I think that's something that's really important. This is just one tool in that communications toolkit, but it's an important tool to make sure that we bring our passport with us, especially to new doctors or people that we may not see that often.
Thank you, Josh, and thanks also for mentioning this is one of many tools, but the overall intention is that we can streamline our conversations and be able to have the best communication with physicians when we have that limited appointment time with them and be able to provide a snapshot. And I just want to say this is a living document, so this might change as you are going through your treatment. But this is a starting point, especially for newly diagnosed patients. This can be really important to understand some of the terms that are used. It's almost like learning a new vocabulary. And if you are newly diagnosed, or even if you've been living with this for a while, there are going to be terms in this document you may not be familiar with. And at the end is a list of resources. Don't worry if you don't know the terminology. You can just flag that as something that you might want to look up. And the resources include some very good references to glossaries and things that are available out there for the neuroendocrine cancer community directly. And we'd be happy to answer some questions on that also. We're going to go through the document and share as a team different sections, and at the end we'll have time for Q&A. Okay, so this very initial part is basics. Your name, very importantly, your year of diagnosis. If you have not been diagnosed, you can just put unknown there. And one thing that's important is how your neuroendocrine tumor was found. Was this because you were experiencing pain and had a scan and that's how it was found, or maybe you had an obstruction? It was found looking for something else, or you were experiencing symptoms that led the physician to think this might be a neuroendocrine tumor. So that's question one. And then number two, I am a neuroendocrine tumor patient and my primary origin tumor is. This is a list of some of the most common places where a neuroendocrine tumor may start. And please understand that there's the primary tumor and then metastases. We'll talk about this a little bit later. But when somebody also has tumors in their liver, that is not a separate cancer, it's not liver cancer. If it's related, if it is a metastasis from the original cancer of neuroendocrine. So these are some, if many people have an unknown primary, so there we included that as well. And some of the more rare Pheopara groups, and another column if we missed something there. Number three, my NET has spread or metastasized to, and then we have a list of some of the most common areas it might metastasize to, including that it has not metastasized, and another column. And what the different columns here are, was this, what are these metastases present when you were diagnosed? Many patients might be diagnosed with, say, a small bowel carcinoid, and then but they also have liver metastases at diagnosis, so there's a place to indicate that. Sometimes those are found on later imaging and are progression, so we left areas there for the date as well and to fill that in.
Why is it important that you know where the primary is? What will that help you with?
So the primary tumor is very important to know, Josh, because it really helps us have a discussion potentially about prognosis. Prognosis is slightly different depending on where the primary tumor arises for a neuroendocrine patient. In addition to that, what's really important is that treatments for neuroendocrine tumors are slightly different depending on where the primary tumor is arising. For example, some of the treatments that we might use for pancreas neuroendocrine tumor might not have as good activity for small intestine neuroendocrine tumors or even lung neuroendocrine tumors. So knowing the primary lesion really allows you to have an understanding of what potential FDA-approved treatments are available for your neuroendocrine tumor. In addition, in terms of clinical trials or innovative therapies that are being tested, oftentimes they have specific criteria for what the primary neuroendocrine tumor that they are looking for. So certain types of clinical trials might be restricted to just pancreas neuroendocrine tumor, while other trials might encompass all neuroendocrine tumors, including pheochromocytoma as well as paraganglioma.
Excellent points, Dr. Lee, and a perfect segue into our next section. I'm going to pass it now to Lisa for question 4.
Okay, so this next section, the whole next part of it, goes into pathology. And under question 4 on the right-hand side, you'll see that we actually indicate I brought my pathology report. So before we go any further, I'm going to kind of go into a little bit into record keeping, which comes up at this point. So our pathology report is something that you get after an operation because the surgeon usually sends it off to pathology and they test it. And that is one example of many of the reports you may get along your journey. Other examples are scans, labs, but pathology is an important one, and your operative report. So what do we do with all these pieces of paper or discs and information. So I know that when we started off in our journey, we started with a basic 3-ring binder, put some tabs in it, and kept our notes from our doctor's appointments, all the scan reports, pathology reports, operative report. And then pretty quickly, we outgrew the 3-ring binder and moved to filing cabinet, especially when you start adding in the actual discs of the scan. Soon thereafter, I moved into electronic format because that enabled me to pull it up very quickly, to email it to a physician if I needed to. Understanding, of course, emailing does not protect patient privacy, so that's a patient's choice to email. But physicians and hospitals never ask for you to email it. They usually request you to send it by mail or by fax. But having it electronically put the information on my fingertips so that I could quickly refer to it. I could quickly transmit it if I needed to for another opinion. It also helped me to be able to pull it up really quickly and compare scans. And I liked certain programs that are out there that will sync between devices, so I would have it accessible on my phone. And one way to keep those electronic records is just go on the patient portal from whichever institution you receive care at and save the labs or the scan report each time you receive them. And then save it directly to your laptop or desktop and have a running folder. And then you have updated scans and labs accordingly. The other thing I put into practice was every time my husband was getting a scan done, I would walk over to medical records and ask for a disc, or 2 or 3 if I saw another NET specialist, and have those on hand ready to send off to my other specialists. Of course, that would require signing a release of records that your institution, depending on their policy, may only have active for a year at a time, so you'll have to remember to go back and sign another or fax in another release of records. So this is an example of a pathology report, and not all pathology reports look the same. But somewhere in there, whether it's under final diagnosis, and I have it highlighted, and then also on the next page, it could be under interpretation, there's usually a section that has a number with a percentage that says KI67, and that's what you're looking for. It also has on there question 5, which is the differentiation and the grade. So it is on a pathology report, and it is often in multiple spots, and it could be on the top, bottom, middle, but usually at the very bottom. And so look for that percentage. Okay, and so going back to question 4, that's the KI67, and number 5 discusses both the differentiation and the grades. And here is where I'll hand it off to Dr. Lee to comment on this.
Yeah, so thank you so much, Lisa. As Lisa said, the pathology report is really the kind of the initial foundation where we are able to, as physicians who treat neuroendocrine tumors, kind of formulate our roadmap in a way of a treatment plan. So one of the first things that we look for on the pathology report is this idea of differentiation, meaning what do the cells look like underneath the microscope? So neuroendocrine tumors can be really broken down into what's known as a well-differentiated tumor, meaning that the cells look fairly regular appearing underneath the microscope, or poorly differentiated neuroendocrine tumor, meaning that the cells are actually fairly irregular or ugly appearing. And this is a critical first step in the analysis of the pathology report, because oftentimes poorly differentiated neuroendocrine tumors tend to be more aggressive, and they tend to grow fairly rapidly. And as a result of that, they're oftentimes treated with chemotherapy. Whereas the well-differentiated neuroendocrine tumors tend to be a little bit more indolent in terms of their growth. And oftentimes, chemotherapy might not be the best agent for certain types of well-differentiated neuroendocrine tumors. So along with that, after you have established whether or not a neuroendocrine tumor is well-differentiated or poorly differentiated, then this is where the Ki67 proliferation index comes in, because that will be able to give you a sense of what's known as grading of the tumor. So grading of the tumor is really analyzing, again, underneath the microscope, how fast the cells are dividing. Some neuroendocrine tumors might divide relatively slowly, and as a result of that, they grow fairly more indolently, whereas other neuroendocrine tumors might be dividing more rapidly. So this is where the grading comes in. And the grading really uses the Ki67, which is that special staining to show how fast the cells are dividing. So for grade 1 neuroendocrine tumors, which tend to grow probably the slowest amongst all the neuroendocrine tumors, the Ki67 should range anywhere between 0 to 2%. For grade 2 neuroendocrine tumors or intermediate grade neuroendocrine tumors, the Ki67 has a much more broader range in terms of 3 to 20%. And for grade 3 neuroendocrine tumors, these neuroendocrine tumors tend to divide more rapidly, and the Ki67, as a result of that, is a much higher percentage, generally above 20%. So again, this gives you an idea really how, in terms of what types of treatments might work for your neuroendocrine tumors, and also gives you a potential early sense of how fast the neuroendocrine tumors will tend to grow.
Thank you, Dr. Lee.
And I just wanted to add something. Dr. Lee, if somebody had surgery a while back, how do they go about getting their pathology report?
So usually after someone has had surgery, most hospitals will keep the tumor specimen as part of a pathology block, usually at least for 5 years. And some centers keep it, for more than 10 years. So one of the ways would be to reach the hospital where you had surgery, and you as a patient have the right to actually request for your block. I have had some of my patients actually keep their blocks and everything and bring it to other centers where they're trying to get a second opinion to look at the analysis of the pathology. And oftentimes you can get the original pathology report as well to have a comparison of that.
Thank you, Dr. Lee. So the next questions 6, 7, and 8 have to do with having a functional tumor or a non-functional tumor, symptoms, and for how long. And Dr. Lee, would you mind expanding on this?
Yeah, so neuroendocrine tumors are probably one of the only types of tumors where there's a potential what's known as a functioning component, meaning that certain types of neuroendocrine tumors tend to produce certain types of hormones. So one of the hormones that's most well known, but certainly not the only one that's produced by neuroendocrine tumors, is something that's known as serotonin. So this is something that you might hear about at different meetings or speaking with your doctor, something that's known as carcinoid syndrome. So carcinoid syndrome is a result of the fact that the neuroendocrine tumor might be secreting excess serotonin, which is a protein that's normally used by the body and has effects on overall mood, as well as having certain types of effects on the heart, and then also getting your bowels to move around as well. But too much serotonin might not be good in the case of a patient that has a functional neuroendocrine tumor that releases this excess serotonin, because as you have that excess serotonin, it can cause certain types of symptoms that you wouldn't anticipate otherwise, such as if it's moving the bowels too much, you might have a form of secretory diarrhea or a very watery diarrhea. Sometimes it can also cause flushing, which is when during times of stress or anxiety, or at other times, depending on what's going on in the different situations in your life where you can be more flushed. And certain types of patients can have more symptoms in terms of trouble breathing, or they can have symptoms as a result of its effects on the heart as well, normally. So this is something that's really good to know, because while a majority of neuroendocrine tumors might be non-functional, meaning that they don't secrete any types of excess hormones, if you have a functional neuroendocrine tumor where you have excess hormonal production, you not only have to control your tumor in terms of the size of the tumor, but you also have to control your tumor in terms of preventing the excess release of these hormones. And there's different types of therapies that can target that. Again, serotonin is just an example that I'm using. There are a lot of other hormones that can be released. So, for example, if you have a pancreas neuroendocrine tumor, you can have a release of additional hormones such as gastrin or insulin or glucagon that normally have are hormones that's released by our pancreas. But if they are released too much in a patient that has a functional neuroendocrine tumor, then they can cause their respective symptoms as a result of that excess hormonal release.
So it might be good here also, Dr. Lee, and we might open it up just a little bit in this section to also describe some of those symptoms, because I know being a VIP patient myself, diarrhea means something different for me than it does for carcinoid syndrome diarrhea or versus other types of diarrhea that may occur. And that's the same with flushing and other types of these symptoms. So it may be good to also try to describe what type of what is going on with these symptoms, so that you have a way to make sure that your physician actually understands what you're experiencing.
Yeah, no, absolutely. So let's take serotonin to start off with. So when someone has excess serotonin, then they can have kind of profuse diarrhea as a result of that excess serotonin. But in addition, since serotonin normally affects the heart, there are certain patients that can develop kind of palpitations or racing of the heart when there's that excess release. In addition, again, because it has also functions on the heart, you can have very abrupt changes in your blood pressure. So at one moment, you might feel like you could have headaches. At another moment, you could feel that you're very lightheaded and you're dizzy, and you might have to brace yourself for a fall. So those are all the symptoms that can be experienced. In addition, it can affect kind of various different types of tissues throughout certain types of organs, such as, let's say, the lungs, for example. And if it does that, you might have symptoms such as shortness of breath or wheezing that develops. So all these are symptoms that you should recognize. And if you're having these symptoms, one of the ways that you can kind of facilitate the discussion with your physician is saying that, what type of neuroendocrine tumor do I really have? Do I have a non-functional neuroendocrine tumor, or do I have a functional neuroendocrine tumor that produces these symptoms? For pancreas neuroendocrine tumors, where there's other hormones that are released besides serotonin, so if you take gastrin, for example, patients that have excess release of the gastrin hormone might have very bad acid production. So this acid production can cause very bad reflux, where patients feel like, there's always something kind of in their throat, and as a result of that excess stomach acid production. And over time, if that's not controlled, patients can have potentially ulcerations of the stomach. So they might have bleeding in their stomach, and they might notice that their stools might be, very dark as a result of these ulcers, or they can have, further abdominal pain from this excess acid production. So those are some of the symptoms to recognize in that case. For patients that have, excess, let's say, insulin production from their pancreas neuroendocrine tumor, again, if you have too much insulin, that can really lower your blood glucose very rapidly. And those are symptoms where oftentimes patients will say that they feel very faint if they're not eating on a regular basis. So that's something that you should take very seriously, obviously, if you're having any type of, fainting spells and whatnot. Patients that have...
We'll get into these a little later when we go through some of the blood work as well. So just important to make sure that we not only highlight the symptoms, but what those symptoms are appearing like to us. And not that I'm a doctor or know all of these imaging tests, but it's really important. I mean, Lisa, as you referred to, you were taking discs in multiple sets of discs. Things have gotten a little better. There's better record sharing between many of our institutions, where you can push these images between institutions, and that's been really great. But it's really important to see what type of imaging you've had, whether you've had an MRI, which is that really loud, very long test that uses sound waves really, or magnetic resonance to image the tumors. A CT, what we used to use a lot was an Octria scan for full body imaging, but now many places, and fortunately most places in the US and in other parts of the world, are using a gallium-68 net spot, and it's sometimes referred to as the gold standard for nets, but it really only shows people who are receptor positive, which is about 85% of us. But it doesn't mean that functional imaging, the MRI and CT, is not valuable as well. So I think these are the major tools in the tool set, and it's important to know how long ago you were imaged, so your physician can tell how recent this is, and if they need to order something new to see if there's been progression. Also listed are some other tests, imaging tests and diagnostic tests, including FTG PET, which might be very useful for those who have poorly differentiated tumors. And so it's not useless for people with NETs. It's just a different type of test showing something different. Most of these tests will be given to you in a CD, as Lisa referred to, that you can get and actually move them by FedExing or doing other things, whether they're using Dropbox or other ways to electronically push them to other institutions if they'll accept them that way. There are ways for you to store them in the cloud. There's a service by a company called MimSoft called MimCloud that will allow you to upload them with an image viewer that you can share with the physician's office. So there's many different ways to get your imaging reports and make sure that you have them. But the most important thing is that when you do get imaged, obviously write down the date or the date range that you're getting them. But as you go in, sign that release form so that you in fact can get, sometimes as soon as you're finished, they will have a CD ready for you that actually has the images all there. And potentially if you wait a few days, you'll get a CD that actually even has the report encapsulated in that CD as well, so that when you pass it off, and ask to see if they can store these electronically, and if you are seen in multiple centers, how those centers can share that information around.
Thank you very much, Josh. That's a really good explanation, and just again highlighting the importance of having the disc with the images, because your NET specialists need to see the images, not just the report, but the images. Question number 10 is regards to labs. And again, having the reports is very important. And someone asked the question about what electronic records or app I might use. For me, my personal favorite is Evernote, Evernote, because it does sync across my devices, but it really doesn't matter whichever one of your choice. And on it, I will save my reports as well as some of the most recent labs. We grouped. The first two are the most common labs. Normal healthy people get these checked. It gives very basic information about general health. The first one noted is the complete blood count, which is a compilation, a group of labs that include your white blood cell count, your hemoglobin and hematocrit, which is your red blood cells, your platelet count, and that's all wrapped up in there. So having the reports and having the dates of it is important for your doctor, as well as the basic metabolic or complete metabolic panel. The differences between that is the complete metabolic panel includes your liver function tests. This may be how it shows up on your report, or it might be split up separately as liver function tests with as a separate lab. So you may see this separately, and then it goes into a group of other labs, and I'll let Dr. Lee explain a little bit further.
Yeah, so thank you, Lisa. The additional labs, other labs that are listed here are, again, just as, potential examples that your physician or provider might be trying to use to kind of follow the growth of the disease and whatnot. So chromogranin A, it's something that we tend to use to kind of maybe track the tumor bulk or the tumor size of neuroendocrine tumors. because in a certain number of patients, they might be elevated. I will say that none of these markers are necessarily 100%, foolproof. Sometimes there can be other medications that can cause elevations of these markers. So they have to be taken in context with everything else that's going on in terms of how a patient is feeling, as well as what their imaging is showing. Some of the other additional markers on this list are, blood tests such as the serum serotonin, or a 24-hour urine test called the 5-HIAA. And this is one of those two different ways that you can be able to measure any type of excess serotonin that may be produced in a patient that has a neuroendocrine tumor that secretes excess serotonin and may be causing some of those symptoms. So that's also good to check, because if you have therapies that are able to target this, then you want to be able to follow this going forward. The things such as plasma metanephrine, as well as 24-hour urine metanephrine, those are really specific more towards pheochromocytomas, as well as paragangliomas, because some of these type of blood tests, as well as urine tests, specifically the metanephrines, are associated with our normal fight or flight response. So if you have excess of that, your blood pressure might be very high, and you could be having symptoms like headache and everything, and you would then need to make adjustments in terms of your treatment.
And I know, Lisa, you may be tracking this either on Evernote, and I know many of the patients that I talk to track, especially blood tests, on spreadsheets so they can watch ranges and things like that. But it's really important here to also note, we do on the top say indicate if abnormal, and also note when you're tracking it what the normal range is, because different labs will have different normal rates. And so what might seem like a really big number might not be a big number because it's a different lab. And really, if you can find one lab to stick with it, that was one thing I learned early on that was hugely important, because especially if you're doing a specialty test that might be completely different and on a completely different scale, one versus the other, you may get nervous for no apparent reason.
Excellent point, Josh. And sometimes the reference ranges will even change at the same lab. So it's really important to look at the fine print there. And I just want to also note on what Dr. Lee said, sometimes different physicians have different philosophies about which of these they're going to follow or not follow. So that's just something to take into account. Great. Well, thank you so much, Dr. Lee. We're going to move on now to surgery, part 5. This is question 11. And for most people, if there is a question about their disease, is it possible to do surgery? Is it operable? As a starting point. And so question 11 is surgery to remove the primary tumor, and whether you've had that or not. So for example, in my case, mine was a small bowel carcinoid, so that was my original surgery. Other people would check whatever their primary was, and the date. And then there's a surgery to remove any metastatic tumors, question 12. Any procedures that might have been done, whether liver-directed or surgically, to address metastases that have happened. And also, again, keeping the reports, and as Lisa mentioned, even the operative report, which can be quite long, but will have a lot of information in there, especially if you do see another physician who might want to look at that operative report. Great. And then question 13 is about other surgery. It's quite common for neuroendocrine patients to have their gallbladder removed, and this is with the anticipation that they will probably be going on a somatostatin analog, which will be coming up a couple of questions later. and which tends to cause gallstones. So it has been just practice to remove the gallbladder if there's a surgery being done. And then we're going to go back to Josh for liver-directed therapies.
And we kind of mentioned them a little bit before earlier, but these are different types of liver-directed therapies that, and this is probably where Dr. Lee can also step in, but the majority of us who are diagnosed with metastatic disease have metastatic disease in the liver. So the liver is one of those very vital organs that it's not easy to find things that replace the liver, and that is the most important thing, and really the thing that we need to know about as far as what we're doing to it, taking care of it, and directing treatment to try to debulk or to lower the load of tumors in our liver. And so these are different things that can happen, whether it's a radiofrequency ablation to try to zap a few, so to speak, of the tumors that are there, a chemoembolization or a bland embolization, and even radioembolization, which all really take advantage of the fact that blood flows to a tumor on one type of blood line as opposed to two for normal tissue, and that we can actually kind of hold off that blood supply to the tumor and really fill it either with, in the case of chemoembolization, little beads that are impregnated with a chemotherapy agent to try to cause damage to that tumor and cut off the blood supply. In bland, we're just filling it with kind of beads that block up the blood flow, because again, we're trying to stop our tumors like blood flow, and so we're trying to stop them. So this is important here. And TheraSpheres and SearSpheres, instead of these beads being either chemo or just kind of blank beads, we're impregnating them with Y90, a radionuclide, also to cause not only to stop the blood flow, but to cause a DNA cell break, to cause cell death and destroy the tumor cells. So these are important to know because we want to have a mapping of what you've already done to your liver, because it's a really vital organ that we need to keep track of what therapies have gone there.
Great, Josh. Thank you. And in the interest of time, we're going to keep going to question 15, somatostatin analogues. As I said, these are, for many people, first-line treatment. Sandostatin, basically these drugs go to the receptors of the tumor cells, and the goal is to reduce serotonin in our whole system. So we have Sandostatin LAR, which is a long-acting, usually given every 28 days. And there's also a short-acting version of that, of octreotide, which can be injected daily or several times a day. Some people use it for breakthrough if they're having extreme symptoms or stress. And then Somatostatin depot, which was approved in 2014. Lanreotide is another name for that. And then a even newer drug called Zermelo, which was approved to help with carcinoid syndrome specifically and quality of life issues, which also helps with reducing the serotonin in the body. And we're going to move on then to I think this goes to Dr. Lee. So we're question 16. Now we're going to talk about some of the chemotherapy, biologically targeted, and other immunotherapy drugs, including clinical trials, and also PRRT. This is a broad section. This is just meant to capture a bit of what you might have had in your treatment plan without going into too much detail right here. I just want to mention for PRRT, there's some excellent references out there, and one is included prrtinfo.org, which is a website that was created by Josh Mailman and Gary Murfin to help patients understand more about PRRT, which was just approved in the United States in January of 2018. So, Dr. Lee, could you please take us through some of these other treatments?
Sure. So the key to why this is really important is because as physicians, in order for us to really help you better as a neuroendocrine tumor patient, we need to know what you have had previously, so that we can understand what therapies are available for you going forward. In addition, for clinical trials or innovative therapies, oftentimes those clinical trials might have specific criteria in terms of have you had a certain drug before you're allowed to go on that clinical trial. So that's very important. So usually we kind of break it down in terms of kind of biologically targeted therapies, which would be the everolimus or sunitinib on this. So everolimus has activity for most neuroendocrine tumors, and is approved for most neuroendocrine tumors, whereas sunitinib is a specific biologically targeted therapy that's oral pill, just like everolimus, that's specifically indicated for pancreas neuroendocrine tumors. Other therapies on this list are really chemotherapies. In terms of Xeloda is a oral chemotherapy drug that's taken, as well as Temodar is also another oral chemotherapy drug that is taken. And usually this combination that's called CAPTAM has activity specifically for pancreas neuroendocrine tumors. And there was a trial that was recently presented at our National Cancer Conference that showed that for pancreas neuroendocrine tumors, this is a really good regimen. The other chemotherapy combination that's listed here is cisplatin and etoposide. This is a combination that is oftentimes used for, particularly for poorly differentiated neuroendocrine tumors. So really kind of the high grade, rapidly dividing neuroendocrine tumors, your physician might be recommending kind of IV chemotherapy with this combination. And as Giovanna mentioned, PRRT is a new FDA-approved treatment this past year, and that is available right now for patients that have neuroendocrine tumors of the GI tract as well as the pancreas. And the hope is that it can be ultimately have a broader indication for other neuroendocrine tumors that expresses the most common type of protein known as somatostatin that are found on neuroendocrine tumors.
Great, thank you so much, Dr. Lee. So we are going to go to the last section on the document, which is the final questions are really more personal about are you diabetic? And this is important to know for the physician because it might affect some of their treatment plans. And some notes on diabetes if you are diabetic. Allergies, medications, food, perhaps you have an allergy to some of the contrast agents that are used in the imaging studies. These are important to note here. And family history, we're looking for specific cancer. There isn't room here to put your entire family history, but specifically as there's cancer in the family and any other rare diseases. Question 20 is, I have had genetic testing, a yes or no question. More and more, especially as immunotherapy is coming on the scene, genetic testing is becoming very important to have molecular profiling and understand more about the tumors themselves and their pathologies. And so some patients may have that done, or it may be referred by their oncologist. 21, as we all know, medications will not fit in these 3 lines, but the idea is to remember to include. I try to keep an updated medication list so that I'm not filling that out every time I go to a different person, but include all of the vitamins you might take, digestive enzymes, anything else like melatonin, and not just your prescription drugs. And then moving to question 22, who is your current physician team and your medical team? We know as neuroendocrine cancer patients that we see a multidisciplinary team. And we're fortunate to be in an area where we're seeing specialists. We have really a wheel of different specialists that all contribute to managing our disease over a long term. And so there's endocrinology, cardiologists, a patient navigator, interventional radiology. We talked about some of those liver-directed therapies, so interventional radiology, the surgeon, our oncologist. There really is a large team, and then including social support. For some people, it's going to change over the years as they're living with this disease and maybe need some help on the psychosocial side. And how has this affected your life? How has it affected your employment, not being able to work, finances? There's a whole other side of how we can work together in terms of social support with the medical team. And then we left a page for some notes to ask your physician. This is be an ongoing section. And we just want to emphasize that this document, Net Vitals, is really provided for educational and informational support and information and to help you track your disease. But we really advise that you consult with your physician for your best treatment plan. And I want to thank our team for being here. Lisa Yen, our program director for LACNETS in studio, and Dr. Dan Lee joining us from Duarte at City of Hope, and Josh Mailman joining us from New York City today. So thank you everyone for being here. We're going to open it up for questions if you have a few minutes to stay with us.
And I know while you're getting some questions, again, this is one tool, and if you're comfortable with paper and printing it out, that's great. If you find an app, I know that some of the Carcinoid Foundation has an app as well for tracking your symptoms. You need to do what's important for you to be able to track what's going on with your disease so you can have a better conversation with your physician.
Yes, and hopefully by having this as one of your tools completed, it will help you learn some things that you may not have thought about and help you come in and formulate those questions for your physician. I think we have some questions online. Okay, is there any other treatment for neuroendocrine pancreatic cancer which has spread to the liver? Currently taking Xeloda.
Yeah, so for pancreas neuroendocrine tumors, there are a wide range of treatment options. From, as we mentioned, from any of the biologically targeted therapies such as everolimus or sunitinib to PRRT are all options that are potentially available. So what I encourage is obviously it's very individualized. Speak with your physician regarding what potential options are, and go from there. And in addition to those FDA-approved treatments, there are several clinical trials nationally as well as internationally that are looking at additional agents that have activity for pancreas neuroendocrine tumors.
There's a question, I'm not sure how to answer this. When will the apps available in the United States be available in Canada? That sounds like a question for that might go to the Carcinoid Cancer Foundation, who works with providing that app, Health Storylines. So another test, what test would you try for poorly differentiated neuroendocrine cancer with no primary, where the primary hasn't been found?
Usually, like the initial test for poorly differentiated neuroendocrine tumors is a FDG PET scan. So that you have a kind of a broad picture in terms of where the disease is located. Usually on FDG PET scan, you might be able to find the primary, whether it's from the GI tracts or oftentimes from the lung. So that's kind of going from that. Sometimes there are a subset of patients where despite having all the scans done along with the section that Josh was talking about in terms of upper endoscopies and colonoscopies, that the primary is now found, then you would have to treat it broadly in terms of targeting what you suspect potentially where the primary is coming from. And this is where kind of a pathology report might be able to help sometimes because they do additional staining that might hint at possibly where the primary might be arising, and you can tailor your therapies based off of that.
Great, thank you. We have another question, which is, I am willing to relocate for the best care and support. How do I go forward to begin my search? I think there's several answers to this. One is to seek out other patients through support groups. I was initially introduced to a support group which has helped me meet other patients to direct me towards some specialists. I think in general we know that patients who see specialists do better, people who see many neuroendocrine cancer patients in their practice. There is a list of specialists on the carcinoid.org website for different states. There's also a list on that website of all the different support groups across the country. So if you were willing to travel, maybe visit a support group. And those, just on our panel here today, there's the LACNETS support group in Southern California, NorCal Carcinet in Northern California. There are conferences happening for patients to attend, and that's a great place to actually meet physicians in person. Anyone want to add to that?
So can I change the question around a little bit?
Sure.
Dr. Lee, you've seen over the course of the last 5 or 6 years, and maybe an explosion is too big of a word, but a great deal more doctors following neuroendocrine tumors, the growth of NANETs and professional societies that track neuroendocrine tumors. Do you think someone needs to actually move in order to get good health care for neuroendocrine tumors, or are we starting to populate around the country, the U.S., and in a way that you can see a local physician but be referred to a specialist when needed, or in collaboration? Do you collaborate with physicians outside your area, for instance?
I think the landscape is somewhat changing because we are really trying to put patients first and make sure that education is the fundamental backbone of what all our professional organizations are trying to do, and really spread the word to improve care for patients with neuroendocrine tumors. Traditionally, patients might have gone onto a site like Carcinoid Care Foundation and found a list of experts, but that's not a comprehensive list because there's it's not updated regularly, and you're not able to be really getting who are the people that are treating this disease. In addition, because of the outreach programs that we've done on a national level, there is that interest to help the patients locally, even if they don't see as many neuroendocrine patients on their own, and work with the experts that's part of those professional organizations to kind of coordinate care so that patients don't necessarily have to travel. I think oftentimes it's very difficult for patients having to, fly across the United States to see one expert when their local doctor can maybe reach out and work with that expert and coordinate care. That will cause a lot of, one, it can save money for the patient, but it takes its toll, keep on flying across the United States to see a physician. So I regularly work with a lot of our physicians locally. So, for example, I have several Kaiser physicians that might not see neuroendocrine tumors as much as I do, who will call me and ask me for advice, and we can, kind of team up together and really kind of coordinate their care so that a patient doesn't necessarily have to, kind of relocate to do that. So I think if you have, it goes both ways. I think if you have a good doctor, someone that really cares about you and is willing to learn about the disease and work with others in order to coordinate your care and really put you as their number one priority, which, all good doctors should be doing, then you can have that coordination of care with experts and really get that care locally without having to travel across the United States to do that.
Yeah, and I'll flip one more part of that answer is I think the most important thing is to, whether it's a good support group or a good support network where you live, because in fact, most of the time is being spent being cared for by fantastic caregivers that so many of us have, and community, and making sure you have that community around you to take care of you is really hugely important. Back to you, Lisa and Giovanna.
Yeah, thank you for bringing up the caregiver also. In fact, we will post a link. Lisa and her husband did a meeting for LACNETS a few months back and talked exactly about this, what it was like for them going through this together as the patient, the caregiver, and it's gotten a lot of positive response. I think it's helpful to both caregivers and patients understanding both sides of that. So we'll post that link. And there was one other question that came up I wanted to address, and it was, do you think it's important for a pathologist with neuroendocrine cancer experience to be looking at your tissue? And I do remember, Josh, you can correct me if I'm wrong, I think it was Dr. Pam Coons at Stanford who said they did a study where they had the pathology redone on their neuroendocrine cancer patients, and up in 30% of the time it actually changed once somebody with a lot of neuroendocrine experience looked at it.
Actually, it's an abstract. It was done by a pathology resident at Stanford, and it was coming from a secondary or community setting pathology into Stanford. And you're right. Actually, it was pathology that would cause a change of management was 30%, which was
Wow.
really high to me. And we have, and I'll make that available. There's a link on the Norfolk Carcinet site to that paper, but I'll certainly send you the link, Giovanna, so you can put it on the LACNETS site as well. It was an amazing document. It's we talk about our team and the multidisciplinary team, and while we talk to Dr. Lee and we'll talk to our interventional radiologist and our nuke med doc, very few of us have ever talked to our pathologist and know who our pathologist is and know what an important part of our diagnosis is done by pathology. So it really is important to read that report or know that it's there and that the Ki-67 was actually done on it, especially as a NET patient, and to know if you're done in a community setting that you may want to have that reread. Yes,
and what you said about the pathologist is so true. We have a couple of videos with NET specialist pathologists on our website, and they literally work with the surgeon. So they're on call during the surgery, and the surgeon will wait to understand what the pathology is during the surgery. So it's really critical, and that 30% I think really speaks volumes.
Yeah, I think it's super important to have the pathologist as part of your multidisciplinary team. So here at City of Hope, our pathologist attends all our tumor boards because it's absolutely critical in terms of laying out the correct treatment plan. And oftentimes when pathology is re-reviewed and additional stains are obtained, it has, as Josh indicated, as well from the Stanford abstract, it has changed, management.
Great. Well, thank you. I want to respect everyone's time here and thank everyone at home who has joined us around the world. We really appreciate you being with us. Feel free to continue to post some questions. We will try to get them answered. And stay tuned to the next Net Vitals. Thank you. And I want to thank our panelists, Lisa Yen, Dr. Dan Lee, Josh Mailman, and behind the scenes, Lindsay Judavine, and Rick Tamayo at TVP Studios. Thank you.